Open, outspoken, it's Ophthalmology Off the Grid, an honest look at controversial topics in the field. I'm Blake Williamson. Welcome to another episode of Ophthalmology Off the Grid. In this incredible episode, my co-host Andy Corley and I are joined by some of the pioneers of Phaco, two gentlemen who helped make cataract surgery what it is today. We take a deep dive into the motivation and thought process for Phaco back in the 60s and 70s, the subsequent learning curve within the OR, and so much more. Coming up on Off the Grid.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Welcome to another episode of Ophthalmology Off the Grid. I'm joined by my co-host Andy Corley today to bring to you what I think is going to be an amazing episode of the podcast. And we're talking to some original Phaco cowboys here, some of the guys that really got Phaco off the ground and made it to what it is today, to be honest. We're very lucky to have two guests with us today to bring us way back when this was all getting started, all the way back to the 60s and 70s. Andy, why don't you tell us a little bit about who we have with us today?
Well, thank you very much, Blake. And it's my pleasure to bring on to the show Dr. Chuck Williamson from Baton Rouge and Dr. Jim Little from Oklahoma. You know, we enjoy marvelous advances now in vision therapy for patients who have cataract surgery. We live in a world where a 2-diopter miss is a serious issue for most refractive cataract surgeons today, but we stand on the shoulders of those that went before us and really went through the trying and difficult times of creating an entire new category of now the most commonly performed procedure, and that is cataract surgery. So I'd like to thank Dr. Chuck and Dr. Jim for coming on today and sharing their experiences with us. I think a good question to get the ball rolling would be, when there really was no foldable IOL available or Insight, what was the real motivation to go to Phaco in the early days when there really wasn't the ultimate payoff of all the refractive benefits that we all now enjoy? Chuck, why don't you get us started, then we'll have Dr. Little comment.
I was lucky enough to have in my residency in the late 70s, the example of people like Dr. Little, who was the head of me, Jim Gills, and people like that in my residency. I did my residency at the Eye Foundation Hospital in Birmingham. At that time, all cataract cases that were done could be done outpatient, but only at a hospital. It was not until the early 80s that actually you could do, you get paid to do cataract surgery at a freestanding surgery center. So we had a 105-bed eye hospital there in Birmingham and about 6 operating rooms. There were 7 residents. The way that we were trained, we got to do a significant amount of surgery there in Birmingham because there was a lot of doctors that did not take Medicare at that time. Medicare was kind of considered something that people didn't fool with, or some of the local doctors did. And so the residents were kind of doing a lot of that. We started off with intracaps our first year and did that pretty much everything. I used the Orisifake. I used McLean sutures, pre-placed sutures. We did all those things, making the 180-degree cuts. That Charlie Kellman actually was the one who was responsible for bringing cryoprobes to remove the lens in intracapsular surgery. And intracapsular surgery basically had the advantage back then of not leaving any residual cortex or residual cortical material or nuclear material in the eye. So the eyes were relatively quiet. The huge advantages of the leaving the capsule in place later was, of course, the protection, the being able to use it for a lens implant, and also the protection from the vitreous. So the second year was intracap. we moved to that. And of course, we still had to do fairly large incisions, not quite as large. We were getting them out. We would, use a spoon to get under the nucleus and get them out. And it was a little bit smaller incision than the intracaps, but still fairly large. You still had to suture that wound. The reason that we at Birmingham were able to do Phacos was that Dr. Callahan, who was the head of the hospital, he started that program. He was personal friends with Dr. Kelman, and they got one of the early Phaco machines there, which, as Dr. Little had we were talking earlier, was about the size of a desk. We started doing Phaco emulsifications in the second year, and by the third year of residency, basically, this was sort of a progression. We were enticed to do that. Most people were not doing that in the community. They were doing intracaps still, or they were doing a few extra caps, but a lot of people were still doing intracaps. But we were enticed to do that from people like Dr. Little, like Jim Gills, like people that basically were able to master that technique. Now, Phaco emulsification was a very difficult time for Dr. Kelman, because some people had horrible results with that. They had endothelial cell loss and basically white corneas. And Dr. Little will testify to this. We didn't look at people with a slit lamp. We pin lighted them in the bed to see if you could see iris details. And that's true. That's exactly what we thought. When we could see the iris details, we thought, wow, that was a wonderful operation. It's not completely white. Sometimes those corneas took a while to clear. However, we still were using that primarily as a method for being able to control the operation, meaning that even with extra cap, you had a big wound, the wound was open, and you basically were trying to get the nucleus out. And there was a situation there for a period of time where your sutures, which were pre-placed, you had to quickly try to tie them down in order to stabilize the anterior chamber. And the thing that Phaco emulsification offered to us was a relatively stable environment when there was basically had that small incision. The early problems that we talked about early were that it was quite challenging once a piece of nucleus exited into the handpiece. You could anticipate this sudden contraction of the anterior chamber. So you had to be careful where you were, where your tip was, where the posterior capsule was, and where the cornea was, so that when everything squeezed down, that you basically were in the right spot to try to not hit any of the other tissues or hit the iris or anything like that. Those were kind of heady days in trying to use that machine. And as that machine improved, yes, we did have to open it up to get these lenses in. And as Dr. Little has said, those lenses, we could do a 6 millimeter incision, which was a huge improvement over extra cap and extra cap. And the idea was not only during the surgery, but post-operatively, we didn't have the problem of the tremendous amount of induced astigmatism that we would have and suture cutting we had to do with putting sutures in the cornea, because that was a huge problem. You'd see some of those old patients that had intracaps, and they would have, 3 or 4 diopters of against the rule astigmatism from the wound relaxation up above. And that was, they were always in glasses. So our goal, because most people were in glasses in the early going, we only had an 18 power lens to use. There were no lens formulas. And we knew they were going to have to use glasses. But our goal was to reduce the astigmatism in those cases. But that's kind of one of the reasons, the astigmatism reduction and the control of the anterior chamber that we were doing. It was a procedure looking for a lens.
Dr. Little, do you remember where you were when you first heard about Phaco emulsification? Do you remember can you take us back to the first time you were even told about it, and what did you think about it?
I was really unhappy about the large incision and the way it would heal and the post-operative astigmatism and so I was very happy to see the procedure that Kelman devised to do a small incision. He actually did use a 2.5 millimeter incision on his first 12 cases. His first 12 cases were people that had blind eye, and he convinced them to allow him to remove their lens with the procedure of phacoemulsification. That must have been really interesting because at that point in time, Cavitron had the dental tip, that removed the tartar from the teeth, and it would vibrate in all kind of different ways. And so it was 28,000 cycles per second of ultrasonics from a generator that was fueled by plugging in the wall, and it would convert it to 28,000 cycles. So his first machine was with a needle, with the irrigation aspiration, was about 14 inches. The handpiece was about 14 inches long because of the 28,000 cycles. In other words, the size of the nickel cadmium strips that worked by the fact that when they received a charge, they would constrict, and when the charge was reduced, they would expand at any rate. They were just almost like fluid. And so that first tip handpiece was so big that Charlie had to build a parallelogram to hold it, the weight of it, and maneuver it around like that. So the engineers said, well, we can make that handpiece any size you want. All we got to do is change the generator, and we can go to 60,000 cycles per second, which made a little bitty handpiece. I mean, that would be actually cumbersome to use that small of a handpiece. So Charlie selected the 40,000 cycle generator, and that's the size of all the handpieces today. But if you increase that, the cycles per second, you can decrease the size of the handpiece. But that was using the nickel cadmium strips. Then the piezoelectric crystal came along, and it had the same physical effects. As the charge went through the crystal, it would constrict, and when the charge was broken, it would expand. So it worked just as well as the nickel cadmium strips. It even better because you could make the handpiece any size you want. It's so dependent on the length of the strips, had to match the speed of the generator. So you had to make the generator power or speed coordinate with the size of those length of those strips. That went away when the piezoelectric crystal came into effect. Then you could do about anything.
So Dr. Little, Chuck was in school and you were in private practice when Phaco came along. How'd you learn? What was the process for learning to do Phaco?
It was in 1968. I was in the surgery dressing room, and a general practitioner had just returned from Tokyo, where Charlie Kelman had presented those 12 initial cases of his. And he said that Dr. Kelman was able to remove the cataract or the lens through a 2.5 millimeter opening. Well, that made me blink a few times, and I got a hold of Charlie, and I said, "Hey, that machine you got there, is that available?" He said, "No, not yet. It's 1968." He said, "There's so many things we still have to work out. There's a lot of problems that this machine hasn't faced yet." So I called him in 69. I called him in 70. Called him in 71. He said, "Okay, we got it. Ready to
Well,
Did you work with him on any of the early designs? Like, did he ask for feedback, or was he pretty private with his, that intellectual property?
Early designs, Charlie did it all himself. He did it all with him and his engineers, and he would make the handpieces. He'd do all this stuff. He was working with Cavitron Corporation then, and they made that dental, vibrator thing. And after we got the machine, and we were working with it. Well, of course, I noted all the problems that machine could create. You had to really dance on the foot feed. I mean, just dance, because if you held that down, then you could get a collapsed anterior chamber. You could get, break the capsule, injure the cornea. But you had to just actually tap dance on that thing to keep those problems from occurring. The way it worked is 3 steps. You push down on the foot piece, and step 1, the first click, was just irrigation only. Step 2, a little further down, that's number 2, that's irrigation and aspiration. Then step 3 was introduction of ultrasonics. So it would come on out of the blast that was full power, more or less. It worked. That was great when the lens was full, a whole lens. But when it got down to small particles, that full blast would just knock it away. The vibration, knock it away, and it was really difficult. So I went out to California and met with 4 or 5 of their engineers, and I said, "Here's what we got to do. We need a foot feed that's like a car foot feed. When it goes down and to click 1 into irrigation, that's great. When it goes down into number 2, when it's in Phaco mode, that'll add the irrigation, and then when it goes into number 3, it needs to be a variable. In other words, it start off in position 3, and it's very low ultrasound, very low power. As you increase it, it's just like you increase the speed of a car, and it gets faster and faster and hotter. And so when you had those small pieces, you could just barely get it into position 3. The vibration would be very low, and it would just gobble those little pieces right up instead of knocking them away. So they changed the machine so that it would do that. Well, at that point in time, the great big desk size was out. It was obsolete by then. And 007 or something, that first little desktop, about the size of a little desktop TV. And then when I was with Optical Microsystems and worked with their engineers, we actually developed a shoebox. They called it the shoebox Phaco machine. It was no bigger than a shoebox, and it did all the stuff, everything.
Dad, I think one thing that I heard you talk about, and I want you to comment on this, is this was very controversial at the time. I mean, a lot of the professors and sort of the old guard were not excited about this at all. Right, you were finishing your training right as this was happening, and Dr. Little was kind of living it in the real world. Can you just talk about kind of what the perception was sort of the from the academic side and the bigger institutions versus sort of the people in private practice like Dr. Little going out and making this actually work?
Up to that point in time in the history of ophthalmology, it was sinful to do something your professor didn't teach you to do. So you're automatically an outcast if you could do something better than he could do, with a new procedure. So a lot of professors were, the younger ones were more for it. They said, that we need to progress along the way, and this is definitely one. The older professors, they didn't even know how to use a microscope, operating microscope. They used loops, the jeweler's loops. So that's step 1. You got to learn how to use an operating microscope before you ever touch Phaco. And then the red reflex is a very, very important. You have to have the light source right next to the visual axis, so that you get a bright red reflex. That lights up the posterior chamber, and you can see what you're doing. You can see the capsule, and you can see all that. Everything you need to see, but there was a scope that was real prominent at the time, and it was 6 degrees off of the visual axis. So the posterior chamber went dark when the pupil got down to 6 millimeters. Well, it was not uncommon for the pupil to get down to 6 millimeters. It was ideal for it to stay wide open, but That just wasn't happening all the time. And then people that had been on pilocarpine for years, they wouldn't even dilate any bigger than about 3 millimeters. You had to have proper lighting, and the Zeiss scopes had that. And then I made drawings and gave it to the other microscope company, and so how they could make their scope work for Phaco. And so they made a device that they hook on the bottom of their scope that with prisms move the light source right coaxial with the visual source, and said, yeah, that's really going to work. And they charged me $4,500 for making that thing for them. So
Yeah, the scopes were a big deal. That was a big deal, Jim.
oh,
They didn't have any at the time, except they had to adapt a ENT scope.
exactly. Yeah, an ENT scope. See, that ENT scopes were Zeiss, and although they didn't have the angle, you had to tilt them down. Your axis was not ideal for the procedure, but it worked. It was so much better than anything else. And then Zeiss made those eyepieces that angle off, and so your view is straight down, and yet your eyepieces are on an angle here, to match your physique. Yeah, it was all fun things.
Once you got all these variables somewhat under control, in other words, you got your scope the way you wanted it, you got a Phaco machine that you relied on. What were volumes like for a busy cataract surgeon in the 80s? What was that? What were those numbers like? How many an hour? How many a week?
I was booked up with surgery, basically almost always about 6 weeks ahead. I mean, I for the next 6 weeks totally booked. And what that was I on Tuesdays, Wednesdays, and Thursdays I would do 9 cases, and on Fridays I would do 15. And with follow up and all that pretty much filled a week up.
I came along a little bit later, and when I got out, my brother had a practice. I got out, and at that time in 1980, you could not do surgery in a freestanding outpatient surgery center. We had to do surgery at the hospital. So the local hospital that we did surgery in when I got out would make us go there and sit most of the day, because they wouldn't, being the young guys who just got out, they had the older doctors in there, and they wouldn't give us block time. So we would have to go and do a case and then come back and sit down in the doctor's lounge and listen to all these doctor lounge stories and doctors telling people. And some doctors just sit there all day drinking coffee. And then they would do a belly case and maybe some other case and some other case. And then you would jump in and get to do another case. And then you would get to another case. It was an all-day affair.
Oh, yeah.
To get that done, until I said, when I got out, all surgery is going to be outpatient, and we need to start building an outpatient surgery center. So I started the plans in 1980, and the approvals, I think, came around 83, 84. I'm not sure, one of those dates, but we had one of the first Medicare certified surgery centers, simply because Medicare didn't certify you to do, didn't pay for outpatient surgery center, freestanding surgery center, paid it in the hospital. So when we were doing it, the reason I was doing it was I could get the equipment I wanted. I could get the efficiency I wanted. We built a couple of operating rooms. And back then, they had no real guidelines. So you had to build these operating rooms, these outpatient surgery centers, almost like a hospital, tile all the way up and the whole thing. And it was kind of a Taj Mahal type of thing, very expensive. And we were very young guys. And then we kicked off with a grand opening, which nobody had ever heard of. And we got Senator Long, who's from Louisiana, who was head of the healthcare, who was head of the finance committee. And he looked at us as young guys and he said, "You boys have a big investment here." He's from Louisiana. And he said, "You really need to do as much as you can because the government's going to get you." And I said, "Well, what do you mean, Senator Long?" And he said, "You boys in healthcare leave big tracts." And at that time, medicine was only about 10 to 11% of the gross domestic product. and now it's close to 18, 19%. And what he meant is that we were expensive. And what we did not know, we were hoping to pay for the thing and just be able to pay the bills. What we did not know was that our surgery would quadruple. And all of a sudden, everybody wanted surgery at our outpatient surgery center. So that's when the volumes took off, 83, 84 for us when we built the center. And we would using 2 rooms bounce back and forth. And at those days, you realize you didn't have all the things you had today with the lenses. You were just putting in lenses one after another. So we could do about 4 cases an hour. So our goal, we operated on Monday, Tuesday, Wednesday, Thursday, and Friday. We did have myself and 2 other surgeons. And you also had an assistant. Your assistant that you were paid, remember, 20% more, Jim. Remember, you could get paid to have an assistant. They would allow you, because up in the Northeast, the surgery volumes were lower, so everybody would assist everybody else so that everybody could be in on these surgeries. Well, we would get a young doctor out of school that would train with us, and we would have him in surgery, and he could do some of his cases, and we would have him assisted, and we'd be paid 20% more. So we would do 12, 13 cases a day, and do that pretty much all week. And like Jim said, you got booked out, so you start to have to increase your speed.
It's amazing how much the efficiency has increased with the types of volumes that we do today. We can do a lot more just because the phaco machines have gotten so much better. Dr. Little, how did you keep going in those early days whenever it wasn't a great machine and you finally got your hands on it in the early 70s, but it was causing problems and there was complications? I mean, what I've heard about you, your legend is that you were the guy that really made phaco work. You were the guy that really, was able to, put that show on the road and teach people how to do it and really get it off the ground. You might not have invented it, but you were the one that, you didn't invent the guitar, but you sure as hell could play it, basically.
We used to say that some people could talk the talk, but Jim Little could walk the walk. No question about it.
It was not an instant thing. In the beginning, I had to learn to avoid those complications with a machine that was capable of creating those complications if it didn't do right. But probably the biggest technique was just to be able to instantly see that something was not right and get off the foot feed. That's what I call dancing on the foot feed, not put it go back in there slowly. But after we developed the accelerator thing, where irrigation was constant, and then that's irrigation aspiration only with no phaco when it was in that mode, then the aspiration was accelerator used by pushing down further and further the higher the vacuum would create. And so you could control that really well, with those changes. The beginning, it was really difficult. There was a steep learning curve that the guys just kind of jumped in there and started doing all kinds of cataracts. And if they had any brown discoloration in the lens, that was an indication of hardness of the lens. And the browner I got, the harder the darn thing is. And I had a guy, a student of mine, that he went back and he didn't pay attention that if they got the brown, then in a cap or extra cap, don't do a phaco if they're browning the brown lens. Well, he went ahead and did phaco. Ultrasound time was 45 minutes. I mean, that eye never cleared up, the cornea, everything. So the machinery got better and better and better. We finally figured out how to make changes that eliminated those collapses and things like that.
What was that like once it did start getting better and better? the previous, all those doctors that used to yell at y'all at meetings and, throw things, they finally kind of came on board and accepted the technology. What was that like? Was there ever like I told you so?
They got fewer. There were fewer and fewer of those. In fact,
They disappeared.
they ended up referring a lot of cases to us. So, to me, when they got older and they didn't want to do surgery, who'd they send them to? So a guy they didn't least like, they'd send them to me. And it was great. And then I got all the measurements. I had technicians that did all the measurements, all that stuff, and we did endothelial cell count on every patient pre-op, so we know just exactly how delicate we've got to really be with our cornea, and then send them back to the ophthalmologist, and he'd see them the next morning and call. I mean, we were very disappointed if they weren't 20/20, the next morning. But we'd also send a note along, and if we had a prolonged case, we could say we could estimate this will probably be 20/40 for a week, then before it starts to clear up. But it just worked really well, and all the older guys, including my chief, Tullis Costin, who trained at Wilmer, he came around. He started sending me patients, but the rascal, he'd send me the brown ones, and then I'd have to do them. I'd have to open them up, and I would tell him. And then, in order for him to kind of have the last laugh, he would say, "Well, that procedure of yours, just doesn't work well. You know that, and I know that. You don't do it on these these people with hard brown lenses." And I said, "That's right, I don't."
Dad used to tell me a story about even though he would do the phaco, he would still go back in and take out the bag sometimes. What was that? What was that about? The alpha chymotrypsin? Because the other ophthalmologists.
That's what Jim had talked about early. People, because pre-YAG, people who were a little jealous of what Jim was doing would say, when his capsules were pacified, they would say, "Well, your doctor didn't take out the entire cataract."
That's
So
exactly.
Jim was going to show him.
Yeah. So when I would finish the phaco and place the lens, I learned to slide under the lens and get a hold of the anterior lip of the capsule and just gradually pull it gently. And I occasionally used alpha chymotrypsin, but I got to where I didn't really have to use it all the time. I could pull it, and I could tell if it was going to give or not. And if it did start loosening, well, then I would just bring it right on out to the incision site. Now then, there's all the cataracts removed.
So do you recall how much time you spent with your peers and colleagues trying to teach them phaco? In other words, you had your private practice, but I know that there used to be a real group of road warriors who on phaco were on the road every weekend somewhere teaching a class. Do you ever look back and say how much time you spent doing that?
Well, the courses, we every 6 weeks, Sinsky and I and Dick Kratz did a course in LA. And so I would fly out on Friday night. I mean, what they would do is Thursday and Friday they would have lab. They would have rabbits and cats and all this stuff, and the guys would practice on those. And then Saturday, almost all day, I would go over all of the things, or quote all the things that are caused by various actions, then how to avoid those, and just go over the actual performance of the phaco. And then on Sunday we'd have a kind of a roundup, and I'd fly home. Just did the same thing in Houston, at Baylor in Houston. Jared Emery organized it and put it on the lab Thursday and Friday. I would come out on Saturday, and we had a lecture more or less, and Sunday we'd just have a kind of a seminar, question answers deals, whatever they wanted to ask about. We would go into that, and I had all kind of movies. In the beginning, before we had the movies that we have now, or just videos, but back then, you had to make a movie, of your cases, and so I had a lot of movies, regarding different things. I made one movie that I had 30. I just started up whenever I was going to move the nucleus into the anterior chamber, and it showed getting that nucleus in the anterior chamber, then another next one, and next one, and next one, just about 30 different cases of bringing the nucleus up, and it was really it really worked good, and they learned how to do that. But you had to be a little bit aggressive, with that until we got with hydrodissection. Hydrodissection, you didn't need to bring the nucleus up anymore. You could tilt it up, you could tilt the edge up, and cut out a pie-shaped wedge, rotate it, cut out. Then the next development was really to divide completely, just to go down through it and make a groove all the way from 12 to 6, and then take two spatulas or one with the Phaco tip and the other with a spatula, and just split it in two. And it was much easier then. You didn't have all that bulk. It was much easier. And then I'd take and split that one half into a quarter and do the other half.
Do you remember sort of the developments in capsulorhexis? Because I know that Gills did the Christmas tree rhexis, and then I guess Gimbel kind of changed that to the continuous curvilinear capsulorhexis. How did you kind of proceed with doing your rhexis?
Well, when in that phase, the lens is whole, the whole thing there, and so when I would make a 3 millimeter incision, I would just tilt the tip up as I used a diamond blade all the way, or whenever I could get it, if I didn't drop it or whatever. But there's also a steel blade that worked just about as well. Then I just tip it down and go into the not 12 o'clock position, but in the 12 o'clock meridian, and in the anterior chamber, make an incision. And then I would go in there with irrigation and a little Sinsky needle thing. It was also called a spizzary needle. It was an irrigating needle, and just guide the tear all around in a circle.
Because there was no viscoelastic then, so you were using water. You were using BSS.
Yeah, I was, and just what you did is just really watched the tear, okay, and you're tearing it down this way. If you're putting pressure, like say straight down, the tear is going to move out toward the periphery. You have to. If you see the tear starting to turn peripherally, you just move the needle or the forceps, whatever you're using to tear it, centrally, and that will change the curve of that tear towards the center. It was just it became really easy to follow what you wanted it to do, but you have to vector the pressure on the tear so that it goes in the direction you want. If it starts centrally, then you move along in the same direction as you want the tear to go until it starts to go peripherally. Actually, it all happens pretty quick. Once you get used to doing it, just make a central opening in the capsule, and then put in the hydrodissection, and watch the fluid wave go right behind the lens if the lens is clear enough, and you could see that wave go right through there, and that thing coming completely loose from the capsule. And after that, it was just slam dunk, kind of. Before we learned how to do that, and before the hydrodissection, it was sometimes very difficult to get the daggone lens loose from the capsule. It really was kind of likes to stay stuck to it. But with hydrodissection, it solved a lot of problems.
Y'all have some sense of how many cases you did in your lifetime? Do you ever think
Yeah,
about?
I counted them up sort of by the yearly deals, and it added up to about 50,000 cases.
Between the two of y'all, I mean, you're already over 100,000 cases in a lifetime.
Yeah.
Hey, Dad?
Oh, yeah. Yeah, we had a lot of cases, and we were doing, like in my case, I've been practicing 40 years. Jim, I guess you started in 68, is that correct?
No, that's when I saw Charlie. I heard about Charlie. No, I didn't get my machine until 71.
So love to get Chuck, you've been at it 40 years. Dr. Little, you've been at it for quite a while, and you still observe what's going on. What do you think of the current state of modern day cataract surgery?
Well, I think that it's tremendous, and I think it's just great. I think the guys, have learned how to really do it, and how to be careful with it, and how to turn to get a 20/20 eye day one after surgery, and I think it's just great. Places that still do intracaps and open wide and all that stuff. I can't speak for those. I'm just talking about the current technology of Phaco and the intraocular lenses, and I just know it couldn't be much better. If you got a good operator, then you got a good result.
In the early days, much of your outcomes and what you were doing were very surgeon dependent. They were dependent on what kind of surgery you did, meaning intracap, extracap. They were dependent on how much inflammation you had. They were dependent upon how much endothelial issues you had. Remember, there were no endothelial cameras when we started out. All sorts of things for people to get better and better and better at surgery. And then the incisions would shrink smaller and smaller and smaller so that we did not induce astigmatism. Then beyond that, something else had to occur, because we were at a point that we could do 10 cases, and maybe those 10 cases would do perfectly, but we were not in control of the lens technology and the formulas to get to where we needed to get to. So the problems as this has advanced is in the case of a perfect case, you still have a lens and you have to choose what lens for what patient. And sometimes choosing a lens, it's more important to choose what sort of patient has what sort of lens.
Exactly.
And what sort of lens the patient actually gets. So you had to start to figure out all sorts of things related to activities of the patient, what they were doing, what they were expecting, and managing the expectations. And then you had to deliver these lenses. And now the remarkable state, Andy, which of course your baby there, is being able to actually alter the outcome of the lens after you actually put it in. Because we were always chasing, like everybody does, every athlete does, every engineer does, everybody changes. You were chasing that perfect case. And the better and better they got, the greater and greater the expectations got. And so therefore it started to leave at some point. You were kind of expected to do everything in the surgery perfectly, and that wasn't like that at all in the early days. Sometimes it was a touch and go. But after that, then the lenses themselves and the technology started to take over, which is where it's at now significantly.
Yeah, I remember back before we had the ability to calculate the lens power. We would just do the cataract and then put in a set, and by history, more or less. So, well, when did you first have to wear glasses? Well, when I was 40. Oh, wait, great. So you knew that they were somewhere going to be pretty normal. But so I asked this one lady, she was 70, she had pretty bad cataracts. And I said, when did you first start wearing glasses? I didn't need glasses. I didn't wear glasses. I said, oh, okay, well, that's great. So I figured that she was kind of normal. So I put in the usual 17 or 18, whatever we were using at the time. And she came back in next day and I said, how you doing? She said, it's perfect. It's perfect. It's better than it was even when I was, a youngster. She was -5 and she had been -5 all her life, never had glasses. She said, oh, I can just see everything.
That's good stuff. Did you ever, and so that grew and grew, and doing all those courses that you did grew. You started doing heads of state and foreign dignitaries and presidents of countries and stuff, and that was pre-internet. So I don't know how people got. Do you have any stories about doing any presidents or heads of state?
Oh, yeah. I had what happened. Well, in London at Charing Cross, the International Cataract Association thing was started up. So they invited 18 surgeons from countries all around the world, Russia, China, everywhere. And they had about 6 Americans there on the list. And they had at the hotel about a couple of blocks away, they had closed circuit TV, and they had TV at every table, at the up front. But so the king of Saudi Arabia sent his brother, who was at that time the ambassador to Iran, and so he sent him to he sent 4 ophthalmologists to that meeting and said, pick out the best Gentile surgeon. I was trying to send my wife to, my brother to. So there was some real questions about his safety. They were worried about. So I heard there was a detective named Sugar Smith he took care of all of the incoming uppity ups and whatnot. And so, the ambassador, he rented the whole top floor of the hospital, and then Sugar and his detectives, they go and take brooms and towels and they twist them all around some kind of way and block the exits, that nobody could come in except through the elevators. And then they had guys there blocking that. And so that was a heck of a deal. And then when he went home, he gave me a 5-ounce medallion that's about that big around. It had the image of King Faisal on the front. It said, and then a big heavy chain that I could wear that on. He said, that's the key to Saudi Arabia. And if you wear that, you can go to any hotel or any restaurant and then show that, and they build the palace. So my wife,
you didn't get the key to the city, you got the key to the country.
Yeah, right. Well, but then we were going to go over there, and then they started having some uprising and stuff. So we never did really get to go over there. And they don't allow a lot of things. They don't allow, cocktails or any. I mean, they're very strict.
Dr. Little, how did you decide it was time to slow down or stop doing surgery? Were you just?
I did that kind of slowly. I got a couple of guys in with me, and they started getting real good. So I started taking a week off a month, traveling. Then I increased that to every other week, and just gradually. By 2006, well, I had tremendous investments in Phoenix and land property and adios surgery.
Do you miss it at all? Do you ever miss it?
I learned not to miss it when I was just taking, like I was down to halftime, there, and I enjoyed being off, and I enjoyed going back, and I miss it, yeah, but wishing to get back into it, no, I never felt like it was a loss to my lifestyle. And I had so many things I like to do.
Some people don't realize they're not only talking to a great cataract surgeon, but they're also talking to a world champion skeet shooter. And that was, you won the world championship in skeet shooting. And then your wife came in after a few years you'd been doing it, and she became a world champion. And then I think you maybe won a championship together. Is that correct? Is that what I heard?
Yeah, that was in 1990. The World Championships were held in South Carolina. So we went there, and so there's a number of different episodes. There's a 410 championship, and there's 28 gauge, and then there's 20 gauge, and there's 12 gauge, and then there's doubles championship. That's where they throw two targets at the same time, and bam, bam, bam. So there were 1,200 entries, and 18 of us got all the targets, got the 100 straight doubles going.
100 straight doubles.
Well, I tell you, we're just getting close to time here. Andy, I didn't know if you had any kind of final questions for Dad or Dr. Little. It's been an amazing conversation. I didn't want to cut us short, but I didn't know if you had any kind of.
This is just wonderful to be able to visit with guys who have made a difference big time in the lives of a bunch of patients. But, there's a lot of your peers that are very thankful that you blazed the trail for them. And, it would have been, I wasn't there in the 70s, but I was there in the late 70s and early 80s. It would have been very easy to just quit on Phaco because it was a challenging procedure to learn. And there was a lot of equipment involved and a lot of financial barriers. And somehow, some way, through the leadership of guys and other ones like you, we got there. And we've got this miracle procedure now. Last week we had Eric Topol on, and after the show ended, he had just had cataract surgery, and now this is one of our modern era commentators on healthcare. He said, "This is a miracle. This is a miracle. I can't believe, I go in for a 30-minute visit and I've got the best vision I've ever had in my life, and I'm 72 years old." So we kind of take it for granted. We take it for granted. We've gotten way too used to it, but it's a miracle, and it took an enormous amount of effort. And I'm so thankful and grateful that I was able to watch as guys like you just led the way and went to all those weekend courses and shared with your colleagues and tried to make everybody better. And it's a wonderful outcome.
During that period of time, the ivory towers just kind of shunned it. They didn't allow it. I finally, Oklahoma University allowed me to do a course out there, and then Wilmer Institute in Baltimore, they allowed me to do a course there. But things just gradually loosened up. And more people realize, like you have, that that's by far the best procedure that's ever been available to human eyeballs.
I would make a joke when I was on the podium in the early days, as things were moving quite quickly, and we had new procedures and people were always skeptical. As I would say, do you know what the difference is between a pioneer and a buccaneer? And people would look at me and they'd say, "No, what?" I'd say, "About 3 years."
I love it. I appreciate it. And Andy and I both appreciate y'all jumping on. We thank you so much, Dad, and thank you so much, Dr. Little. I've heard so much about you from my family over the years, and it's great to finally connect and learn from you. We appreciate you jumping on. Thank you to Drs. Chuck Williamson and Jim Little for joining us for this episode of Ophthalmology Off the Grid. And thank you to our listeners for tuning in. This has been Ophthalmology Off the Grid. Until next time.